Hello everyone, my name is Dr. Abardawlani. I'm a pediatrician. My presentation is about approach to a child with anemia today. As an introduction, anemia is defined as reduction of the hemoglobin concentration or red blood cell uh, below the range of values for that specific age and also for that specific gender. And also, to go further about anemia, we should have to know what is hematocrit, what is hemoglobin, what is MCV, what is retic count, and the like. Hematocrit is a function of a volume of whole blood which is occupied by RBC and it's expressed by a percentage. It is the volume of RBC in the whole blood, so it's expressed by percentage. Whereas hemoglobin is the measure of the concentration of the RBC pigment hemoglobin in whole blood expressed as a gram per 100 ml or gram per deciliter. This is a normal mean and the lower limits of normal value for hemoglobin, hematocrit, and the mean corpuscular value for children at different age. Children have different lower and upper limits for their normal hemoglobin, hematocrit, and MCV value. So it depends on the age and gender of the child. That is why we should have to go and check the chart before judging the result of the laboratory to say anemia or polycythemia in pediatrics, because everything is depends on the gender and the age of the when we approach a child who have anemia, first we should have to check history and physical examination. An anemic child needs a detailed history and sort of physical examination, because we might know the cause based on the history of the child and also based on some physical findings which suggest the cause of anemia in a child who have anemia. For example, age of the child. For example, if term neonate comes with at the age of 10 weeks with anemia of, for example, hemoglobin of 9 or 10, this might be due to physiological anemia of infancy. And also iron deficiency anemia is common in children between the age of 1 to 2 years and the like. And also gender is very important. Some cause of anemia depends on the gender of the child. And also diet is very important. For example, in some areas, anemia can be due to the high consumption of cow milk in children less than 1 year of age, or goat milk can cause folate deficiency and it can cause anemia. In some cases, vegan diet can predispose for megaloblastic anemia due to vitamin B12 deficiency. So the diet, asking the diet of the child is very important. Some medications like cotrimoxazole, different medications can cause anemia. So we should have to ask the history of medication in child. And also anemia of chronic disease can happen. So we should have to ask the signs and symptoms of chronic disease, because chronic disease causes increased production of hepcidin, and this hepcidin causes accumulation of iron in the macrophage, and also it causes decreased absorption of iron from the GI tracts. So chronic disease can predispose for anemia. So asking a child about history of chronic disease is very important. Infectious causes, travel history, for example, travel to the malaria endemic area, and the exposures should be asked. A family history of anemia and associated difficulties like splenomegaly, jaundice, early age of onset of gallstone, and the like should be asked. Clinical findings generally do not become apparent until the hemoglobin level falls to less than 7 to 8. If there is clinical findings, the most common clinical findings that we saw is pallor, sleeplessness, irritability, and decreased exercise tolerance. When we check pallor, we should have to check at the tongue, nail bed, conjunctiva, palmus, and the palmar creases. Based on the severity of the anemia, those areas can become pale. We can also show a flow murmur, so auscultating the patient whether there is flow murmur or not is important. How high output heart failure may result based on the severity of the anemia. The more the severe the anemia, high output heart failure and the flow murmur can be had regardless of this cause. Laboratory study, when we examine a child with anemia, after taking adequate, appropriate history and the physical examination, we should have to go to laboratory. When we go to laboratory, we should have to be specific. First, initially, we should have to check complete blood count, hemoglobin level, hematocrit level, MCV, RDW. Those can be found on the complete blood count. And also, we should have to check other cell lines, for example, the level of the platelets, the level of the WBC count. Complete blood count, even we can diagnose the cause of anemia based on the CBC finding. Reticulocyte count is also very important. And also we should have to check peripheral blood smears. Based on those three laboratory findings, additional laboratory studies needed, or it might not be needed based on the findings of those initial ones, and also additional if there is pertinent finding on a history and physical examination, we might send other laboratory findings, such as we might need bone marrow aspiration, bone marrow biopsy, cause of further investigating the cause of anemia. Differential diagnosis: anemia is not a specific entity, but rather it can result from any of a number of underlying pathologic processes. To narrow the diagnostic possibilities, anemia can be classified based on either the morphology or their physiology. To classify based on morphology, first we should have to know what MCV and reticulocyte count is. Reticulocytes are immature red blood cells, whereas reticulocyte count is used to estimate the degree of the effectiveness of the erythropoiesis. A retic count, it measures the number of reticulocytes in the blood. High retic count or reticulocytosis, this is when there is an increase in the production of red blood cell to compensate for the loss of mature red blood cells. When there is anemia, normally we expect high retic count, because when there is anemia, there is increased production of erythropoietin. This erythropoietin causes increased RBC production in the bone marrow, so there is expected reticulocytosis. If there is anemia and the retic count is low, the bone marrow is not responding appropriately to the anemia. The reticulocyte index or reticulocyte production index should be calculated. It is used to alleviate the effect of premature release of reticulocytes by taking into account maturation time of reticulocytes, in addition to correcting the degree of anemia. So retic index is calculated as percent of reticulocytes that we get from laboratory times the hematocrit of the patient divided by the expected normal hematocrit for that age and the gender times correction factor or maturation factor. This correction factor or maturation factor, it is 1 if hematocrit is greater than 36. It's 1.5 if hematocrit is between 26 to 35. It is 2 if hematocrit is between 60 to 25. And it is 2.5 if hematocrit is less than 50. So if reticulocyte index is less than 2, there is hypoproliferative state. So bone marrow is not responding appropriately. If retic index is greater than 3, bone marrow is doing to respond actively to respond to the anemia. So it is hyperproliferative. In addition to retic count, mean corpuscular volume is important. It's a laboratory value that measures the average size and the volume of red blood cells. The normal range, it varies with age. Or we can calculate MCV by the hematocrit of the patient times 10 divided by the RBC, the initial 2 digits of the RBC. Low MCV is called microcytic, normal MCV is called normocytic, and high MCV is called normally to say MCV is low, normal or high, we should have to have a chart at hand. We should have to have a reference based on the age and the gender of the child. But if we don't have a reference, we can use the age of the child as a lower limit. For example, we can say microcytic anemia if MCV is less than 70 plus age of the child. For example, if the age of the child is 8, 70 plus 8, 78, this is the lower limit of the MCV. So any value of MCV for 8 years old child less than 78 is called microcytic anemia. Whereas normocytic anemia is MCV greater than 70 plus age of the child up to 100. Whereas macrocytic anemia is MCV greater than 100. This is an estimated way to use when we don't have the chart at hand. We say RBC is low, normal, or high by comparing with the size of the nucleus of the mature lymphocyte in the peripheral circulation. In macrocytic anemia, the size of the RBC is lower than the size of the nucleus of the mature lymphocyte in the peripheral circulation. Whereas in normocytic anemia, the size of RBC is equal to the size of the nucleus of the mature lymphocytes in the peripheral circulation. Whereas in macrocytic anemia, the size of RBC is greater than the size of the nucleus of the mature lymphocytes nucleus in the peripheral circulation. Most of the time, MCV is high in newborn and in children less than 2 years. For example, during newborn, MCV of 110 is normal. Most of the time, MCV is between 95 to 121. Between 6 months to 2 years, MCV is most of the time between 70 to 86. So after we get the MCV and retic count, we can differentiate, we can classify the cause of anemia. We can go to our differential diagnosis. For example, if MCV is low and we check the retic count and the retic count is low, the cause of this anemia could be iron deficiency, thalassemia. It can be chronic disease, lead poisoning, sideroblastic anemia, copper deficiency, and the like. If MCV is low but retic count is high, it can be hemoglobin C and E disorder, and also thalassemia syndromes. If MCV is normal for that age and for that child, but retic count is low, it can be chronic disease, it can be RBC aplasia, it can be malignancy, renal failure, acute bleeding, hypersplenism, and the like. Whereas normal MCV with high retic count, it can be due to macroangiopathies like hemolytic uremic syndrome, TTP, disseminated intravascular coagulation, and also membrane defects such as spherocytosis, elliptocytosis, and ovalocytosis, and also enzymopathies like G6PD deficiency, PK deficiency, and the like. Whereas high MCV with low retic count can be due to folate deficiency, it can be due to vitamin B12 deficiency, and the like. Whereas high retic count with high MCV, it can be due to active hemolysis with very elevated retic count, and also this erythropoietic anemia 1 and 3. So having complete blood count and retic count first is very important. From the complete blood count, we get the level of hemoglobin, hematocrit, and the RBC, and also MCV and RDW, and also we can check other cell lines like WBC and the platelet count, and also if we get retic count, after that, based on the MCV value and retic count, we can classify the etiology to the different. Now let us go to the classification of anemia based on the underlying physiology. Anemia can be caused by either due to decreased production or increased distraction. Decreased RBC production may be a consequence of ineffective erythropoiesis, or it can be due to complete or relative failure of erythropoiesis. And also increased distraction can be due to hemolysis, sequestration, and also it can be due to decreased production. For example, iron deficiency, folic acid deficiency, B12 deficiency can cause decreased production. And also infiltration due to leukemia, lymphoma, and also failures, toxins, and different things can cause decreased production as a cause of anemia. Whereas anemia can be caused by increased distraction, for example, in the case of thalassemia, in the case of membrane defect like spherocytosis, enzyme deficiency like G6PD and the pyruvate kinase deficiency, and also autoimmune can cause increased distraction of the RBC, and it causes anemia. The peripheral blood reticulocyte percentage or reticulocyte count or retic index can be used to differentiate the two causes of the two physiologic categories of anemia. It can help us to differentiate whether anemia is caused by decreased production or increased distraction by checking the reticulocyte index. Normally, the normal reticulocyte percentage of total RBC during most of childhood is approximately around 1%, and the absolute reticulocyte count is around 25,000 to 75,000. Low or normal numbers of reticulocytes, despite anemia, generally it represents inadequate response to anemia. This is associated with relative bone marrow failure or ineffective erythropoiesis. So during anemia, we expect high retic count because during anemia there is increased erythropoietin production. This erythropoietin causes increased reticulocytosis to respond to anemia. Whereas increased numbers of reticulocytes represent a normal bone marrow response to ongoing RBC distraction, which can be due to hemolysis, sequestration, or this is all about approach to a child with anemia. On the next lecture, I will bring about overall childhood anemia, causes of childhood anemia. Thank you.